So I was very glad that we all got a new picture yesterday because our old picture was back one of my favorite work trips ever when we went to Nashville and got to listen to country music. But Hunter's Hope, I cannot say how much I appreciate it because I've been a nurse for almost 20 years. And this is the organization out of all of them that I've ever been involved with that appreciates nursing and nurse practitioners. Most conferences I go to, there are no allied health professionals. There are very few physical therapists or nurses. And I always say it's advertised as multidisciplinary, but it's really multi-specialty. And so I greatly appreciate, and I realize that that comes also from the voices of the families. And so I thank you for letting us be part of this. So this is probably now an incomplete list of all of the care coordinators across the country. And our role, I think nurses' role in general is always, I say, to be a translator. Sometimes the world of medicine can use the language that I think that's not always as easy to understand. And although our centers have excellent physicians, sometimes having a second voice and an advocate that can be kind of this translator between families and the medical team can be helpful. And so our role is to help be an extra person that you can call with questions. And so these are some of the things that our care coordinators do. And, you know, helping get referrals, linking families to education materials. And I will say that our center this year was lucky enough to add a nurse as well, who has been a humongous help to me and has helped, I think, patients to be able to have access much better. And then one of the things that's also very special that Hunter's Hope gives us is this ability to meet each other. And so we have a monthly call. We can go over different clinical cases. We've had some industry come and tell us, keep us up to date on clinical trials. And then it's allowed us to kind of think and brainstorm about what we would like to contribute back to all of you and how we can be of service. And so one of my great wishes, and seeing all of the people yesterday and talk about these 20 and 30-year-olds, I'm going to give you this talk, but I know that recognizing that all of you are the real experts on this, I got interested in the transition of care because I say I'm a transition of care failure. I had a congenital heart defect when I was little, and I'm supposed to go see a cardiologist yearly. And I have gone periods of my life when I went 7, 8 years and didn't go. And so I tell people that because I think there can be kind of shame in like, well, obviously I know I'm supposed to be doing this, and yet I am not. Now I am, but I think when you have a pediatric disorder and we now come up with these treatments, which is great, we're going to have children living full productive lives longer and longer. And we need to make sure that they have that message that, yes, you can do all these tremendous things, but it also means you need to be taking care of yourself in ways that are a little different. And so I don't think any of you need to know why transition to care. I recently, people have heard, was on a tour in Alaska and saw this picture of this tree that was just totally uprooted. And I thought it was a good image of what transition from adult or from pediatric to adult care can look like, where oftentimes these children are not able to find providers that know anything about their disease. And then if they're treated in pediatric centers, we don't know anything about many adult diseases. Like I, for example, was not great about talking about sexual function, not really my deal in pediatrics. So that was something that working with some of the adult leukodystrophies is important, and we really need adult providers to help us. And then, of course, the legal issues, which Anna had asked me to try and go over. And I am instead going to say that I welcome anyone to contact me that wants to help us and share your stories of how you did this. I know that it varies state by state. When you lose your services through school in Massachusetts, and I think many states, the change actually begins at age 13, where there are laws related to how much of your child's medical record you can see at that point. And so this is an area that I welcome anyone that has been through it and wants to help us to create better resources. And then the big issue is that currently for many patients, it's a bridge to nowhere. There are not very many adult leukodystrophy centers. And even as LCNs, many of our centers do not have a direct connection. And so this is just a general timeline. People have been interested in this transition of care since the 90s, when treatments for cystic fibrosis and other kind of diseases like leukodystrophy that used to be considered only childhood because we didn't have good enough treatments for patients to make it into adulthood. And one of the keys is to start much earlier than you think that you should start, so that children begin to learn about their health. And this is the model that's been commonly used. And so you can see this works, I think, well, if it's someone like me that has the cardiologist and the primary care. That's pretty easy. That is not the case for the majority of the families we see, right? There's all sorts of specialists, pulmonary, endocrine, neurology. And then one of the huge ones is school-based services. So getting your physical therapy, your occupational therapy, speech, all of that. And so trying to figure out how to connect all of that is very challenging. And so I know our wish is certainly for there to be adult leukodystrophy centers across the country, just as there are pediatric ones, so that you can just transition into an adult program. And it doesn't necessarily mean you leave the hospital you're at. It can also mean that just the focus changes. So at Mass General, we're lucky that we have both a pediatric and an adult hospital. So we're actually able to transfer most of the specialty care within network, assuming people don't move. Currently, we are the neurology, though. We're lucky because this year, just this month, our first gene therapy, or our first adult gene therapy fellows started. So we've had 2 gene therapy fellows prior to this, but Yetta is an adult neurologist that is just focusing on leukodystrophies and trying to develop treatments as well as standard care for adults with leukodystrophy. So she is in our clinic and will be there 1 to 2 years, and then we hope will become an attending. And some unique features, as you all know, is I think one of the tricky things, especially for people that get an adult leukodystrophy diagnosis, which I don't think I heard as many this morning, or I mean last night, like CTX and some of the other solely adult onset, but with these as well, is that it affects so many members of the family. And so, like, unlike some diseases where only one person is dealing with this, you can have, you know, mom has it, child has it. And so who is supposed to be the one that's going to handle all this when so many people are being affected? And then, as I know you all know, the goals of care can change a lot as children become adults. And so, for example, in ALD, which is the disease that we study the most and treat the most in Mass General, the peripheral neuropathy becomes a larger and larger problem as people age, which is similar in other leukodystrophies as well. But so having people that can help with pain management, that's a different, you know, neuropathic pain becomes important. And then briefly, as I mentioned, the legal considerations. And so I'll go through this part quickly, but we've started with ALD, trying to create a transition program in our hospital with the hopes that then, as you have more and more people with MLD and Krabbe being diagnosed and treated early with newborn screening, that this can also translate to all of you. And so one of the things that we have found is that in ALD, there's a risk of having childhood cerebral disease, but there's also a risk of about 20% of adults developing adult cerebral disease. And while we're very good at catching childhood disease once we know from newborn screening, we are not good at catching adults. So of the adult men that we see in our clinic over the last 5 or 6 years, there were 12 with very advanced disease at the time of diagnosis. And half of those men knew they had the disease and just had not been getting MRIs. And so that's, something that's acceptable to us and that we need to figure out how to fix, as opposed to the children where every single advanced case of a childhood leukodystrophy we saw for ALD, none of them knew they had the disease. Nobody had just fallen off of their MRIs. And so this just shows you, and I had added this in part because of preparations as you're thinking about some of the juvenile forms of these diseases. So to show you, in children, we're excellent at keeping kids on target, on having them get their medical care as it's routinely expected. And we do a lot of work to call families and keep on top of them, but we, with those supports, only had 4% of our patients that were considered not completely compliant, which is pretty good. And I was very proud that from 13 to 18, this very small window, we were perfect, but it's also a small group of people. And then in adulthood, it just falls off. So we only had 30%-ish of people that were on schedule. And that's a very biased sample because that's 30% of the people that were coming to clinic, right? Many people are just not coming at all. And so this is something that we need to work on and how we can reach out and contact them. And so we had some interviews with men to try to find out why people don't continue with care. And many of the things were that they had always been going in for screening and it was always fine. So they didn't really see the point of continuing to go. Some of them, a very fair argument, I would say, is that we don't have good treatments for adults. And so why come and see us if we don't have that much to offer because the adult diseases haven't been studied? And then we had a few that had complete faith in their wives and thought their wives would know. And so they just didn't come until their wife saw a problem. And so I reached out to one of the mothers of a patient with ALD that was transplanted when he was around 7 or 8. And like some other people I met yesterday, he's actually 27, but looks much younger to me. I don't know how you all have such good skin. And I asked her what she would advise. So he is nonverbal, but is one of the happiest people I've ever met. He's not my patient. He's just someone I know from conferences. And he just exudes joy. And I asked her what advice she would give all of you. And so this was her words, that preparing for adulthood with a disability opens up a lot of wounds, and that her best advice is to be prepared and remember the goal is getting the best care and support for your child. And I know she's also talked about kind of the fear of what happens if something happens to me, and how do you make sure that your child is going to have care if, God forbid, something happens to you. And so I think that this is an area where we really have an opportunity to all work together, especially seeing how many adults there are at this meeting. It's amazing. And so we really want to work with you to try and figure out what you need, what we can do better, coming up with trials for these adults, and establishing adult centers. So thank you.